The most common cause for preventable mental retardation or developmental delay in pediatric age group is congenital hypothyroidism. And the pathology can be anywhere. It can be in hypothalamus, can be in anterior pituitary, it can be in the thyroid gland, or it can be in the target tissues. But the most common cause for congenital hypothyroidism is thyroid dysgenesis. That means you have a problem in the thyroid gland, as a result of which your T4 is not produced. This is what you see in majority of congenital hypothyroidism. When it comes to physiology, hypothalamus secretes TRH, which in turn acts on the anterior pituitary to produce TSH, which in turn acts on the thyroid gland to produce T4 and T3. And in target tissues, majority of your T4 is converted into T3. So what does it mean? T4 is the storage form, T3 is the active form. And in almost many instances, we rely primarily on the estimation of TSH and free T4 or T3. And as I told you already, the most common cause for congenital hypothyroidism is the problem with respect to the thyroid gland. It can be thyroid dysgenesis, thyroid agenesis, that is structural problem, or it could be due to functional problem in which the enzymes involved in the production of thyroid gland will not be there. For example, thyroid peroxidase deficiency, or it could also be due to iodine deficiency. Very rarely it could be due to maternal antithyroid drugs. By and large, the most common cause for congenital hypothyroidism is thyroid dysgenesis, and when you take ultrasound thyroid, it will be absent. Since there is absence of thyroid gland, when you take TSH will be high and T4 will be low, because your anterior pituitary and hypothalamus are all normal. So in almost all cases of congenital hypothyroidism, TSH will be high, T4 will be low. But despite being a low T4, even when your TSH is normal, TSH should be high. When TSH is normal, you need to think in terms of, it doesn't mean that TSH should be low. Even when your TSH is normal to the degree of low T4, you need to suspect central hypothyroidism involving issues in hypothalamus or anterior pituitary. I repeat, it doesn't mean that you need to have a low TSH in the presence of a low T4. In the presence of low T4, TSH should be mandatorily high. Even if it is normal, consider secondary hypothyroidism or hypothyroidism due to issues in hypothalamus or anterior pituitary gland. It could be due to these congenital conditions like septo-optic dysplasia, germinoma, holoprosencephaly, craniopharyngioma. Right? Remember, in congenital hypothyroidism, you need to have a high TSH and low T4. If you have a normal TSH also, you need to suspect secondary hypothyroidism involving hypothalamus and pituitary gland. Next, certain clues. When you have a midline cleft lip, cleft palate, or some facial dysmorphism, you need to rule out pituitary hormone deficiencies apart from hypothyroidism. Multiple pituitary hormone deficiencies are usually associated with midline cleft lip and cleft palate.